Sickness causes suffering and disruption for the family and may even be hazardous to the other members of the family. Sickness is embedded in a whole matrix of difficult family problems. If the physician is to successfully treat the disease of a person, the psychosocial problems of both the patient and the family must be recognized, diagnosed, and addressed. This session will discuss the impact of illness on the patient and the family following the illness trajectory and some recommendations on how we as physicians can respond. The family illness trajectory refers to the natural history of an illness episode or the normal course of the psychosocial aspects of sickness for the patient and family. It depicts the passage through suffering, a framework for the direction or path of the patient and family's responses across the evolution of the disease. The peculiar responses will enable the physician to formulate a tailor-fit therapeutic plan. Understanding the illness trajectory allows the family physician to predict, anticipate, and deal with the family's response to illness based on what responses are normal and pathologic. Every stage of the natural history of disease has different meaning of illness to the family and the family members. Routinely, physicians investigate the disease by examining clinical and laboratory evidence of biological and psychophysiologic dysfunction. But when we investigate the illness, we explore its meaning for both the patient and his family. The meaning of illness is influenced by their emotions, beliefs, perceptions, and past experiences, among others. The reaction and meaning of the illness depend on various determinants of illness behavior, such as the recognizability of symptoms, extent the person perceives the symptoms as serious, the nature of the onset, information, knowledge, and cultural assumptions, disruption in family, work, and social activity, tolerance level, and even accessibility of treatment resources. Let us describe each stage in the family illness trajectory. The warning sign of a disease initiates the preliminary stage. Medical beliefs and previous experiences influence the meaning of illness. The nature of onset also plays an important role. Today, a person who suddenly coughs can be interpreted as COVID-19 and can escalate anxiety and fear, unlike in the past when a simple cough could just be shrugged off. As family physicians, we should provide an explanatory model for the clinical presentation in order to afford understanding, acknowledge, explore, and address the fears and conflict the patients expose. Diagnostics may also be utilized if warranted. Moving to stage 2, the physician elicits the pertinent features from the patient and brings this all into explanatory model of diagnosis. The physician who presents the diagnosis is responsible for making a clinical judgment about the amount of information the patient can absorb. Give small doses of information over time. Unnecessary frightening anxiety may occur if information are not understood. If the diagnosis is confusing, stressful, and shattering, the family physician must provide support and continuity of care, interpret findings which are misunderstood, offer advice and encouragement, and clarify meaning and specialist's message and outcome of illness and operation. When disclosing the diagnosis, anticipate a number of problems and help families to cope and adapt more through family conference, discussion with parents, and other relatives. Maintain openness, allow sharing and support, address silence and isolation, even abandonment. The physician should know that the feeling of guilt is a natural response. Some family members may have the irrational feeling that they personally caused the patient's disease. Reassure and educate accordingly. The physician should help family members anticipate such feelings and make realistic efforts to relieve patient of self-blame through careful explanation of etiology. For this potentially emotional phase, the physician should assess the likely effect of the illness on the family and predict problems that could arise. Then develop shared plans to realistically cope with the challenges in consideration of their capabilities to deal with such stress. Help the family understand that some problems as well as benefits may come from family and friends who offer support. Offer alternative interpretation of proposed explanatory models to facilitate cognitive acceptance. Stage 3 pertains to major therapeutic efforts. Since management or therapy represents as one of the most challenging and rewarding part of medical practice, the physician must deal with multiple variables working in harmony with the wishes of the patient and the family, and coordinates all aspects of therapy which involve specialists and/or other agencies. Critical issues in choosing a therapeutic plan revolve around the psychological state and preparedness of the patient and the family, as influenced by their belief system and trust on the health system. Thus, the physician should investigate for signs of potential noncompliance and detect those patients who are not emotionally equipped to undertake some form of therapy so that other professional help can be obtained. In this stage, the assumption of responsibility for care should be in place very early in the treatment plan. Thus, we have to establish and define responsibilities of each party and give realistic role to everyone. We expect diligence on the part of the physician in keeping costs down by involving family in all major decisions. Of what good is the plan if the family cannot afford it? The economic impact of illness includes emotional trauma, social dislocation, economic catastrophe, disregard of lifestyle and cultural formation of a family, plus the effects of hospitalization, surgery, and other major therapeutic methods that are emotionally stressful for the patient's family, especially in families who are essentially helpless, unable to participate in the relief of anguish of the index patient. Hospitalization gives rise to stressful logistical problems depending on who is the index patient. Anticipated issues like when the father or breadwinner is sick, as this could lead to economic burden. The greatest impact on the family members results when the mother gets sick, which also poses high risk of family dysfunction. If any of the children becomes ill, a special syndrome of emotional problems can erupt, such as hostility and abandonment of the other siblings. Parents turn helpless, become guilty, frustrated, or hurt. When a geriatric member is sick, the family is vulnerable to fears of death, abandonment, loneliness, and helplessness. In stage 3, the role of the family physician is to anticipate pathologic responses from family members, such as deep depression, psychological reactions, and behavioral problems like addiction, work inhibition, and pathologic acting out. Stage 4 is prompted by the return from the hospital or major therapy. It initiates a period of gradual movement from the role of being sick to some form of recovery or adaptation with corresponding adjustments of relationships and roles within the family. The experience of recovery or adjustment to the illness outcome is an important phase for patients and families. It varies according to the type of outcome anticipated. Debilitating illnesses, for example, will definitely result to more adjustments in many aspects of a family's life. The simplest outcome is a return to full health. The gains from the illness experience is that the patient is nurtured and other family members are allowed to take over the abandoned obligation. The recovering family member must be understood as someone also adjusting, especially when only partial recovery was attained, and or followed by a period of waiting to learn if the disease will return. Fear of death may also ensue because of long period of waiting. They maintain constant sense of vulnerability, possibly requiring acceptance of a known permanent disability. Early adjustment to outcomes must deal with immediate effects of trauma and alleviate anxiety. Psychological support can be given through understanding and repeated reassurance. Explore level of understanding of the patient and the family. Call on other family members for means of support. Try to find out how members understand what happened. What kind of labeling do they have? Do they label the person as still ill? Or do they label him as once again well? Or has completely returned to health? This perception checking manages expectations. The final stage is adjustment to the permanency of the outcomes. The second crisis occurs as the family realizes that they must accept and adjust to a permanent disability. They have to accept that life must go forward, and the pattern believed to be temporary must be accepted as permanent. The family physician should be aware that the continued unwillingness to incorporate that reality of the permanency of the loss may be a sign of pathology. Coping mechanisms are developed during the earlier stage of family adjustment. This can be exemplified by a person who has partially recovered but remains to be fully disabled and is not encouraged to reintegrate into the family or community affairs. If this coping mechanism continues, full functionality of the sick person may be delayed. For acute illness, there is potential for crisis, especially when family routines are suspended. Emotions escalate and can lead to anger, especially if the family perceives that the care given by the doctor is not satisfactory. Because of suddenness of illness, the family may find it difficult to face the stress. What the family physician can do is to facilitate healthy response or acceptance of diagnosis and recognize danger signals such as delayed or prolonged reaction. For chronic illness, because of prolonged fear and anxiety, there is a higher incidence of illness in other members of the family. If the chronic burden brings additional distress and sometimes feeling of guilt, especially if the sick member was previously neglected. The family becomes overindulgent toward the sick, and this will later result into feeling of overworked or overwhelmed. Thus, anger and resentment toward the sick member sets in, leading back to the feeling of guilt later in the course of time. As family physicians, we should encourage ventilation of feelings, give reassurance and reinforcement of care. When caring for terminally ill patients, this is highly emotional and potentially devastating. The moment of diagnosis of a major debilitating or terminal disease is often remembered as the single most difficult time of the entire illness experience. As a reaction to the shattering diagnosis, the patient and his family anticipate grief reaction. If the family is functional, members will be drawn close together to provide care and support to the patient and to each other. However, if the family is dysfunctional, it can be the seed for future family discord and breakdown. The initial response to the diagnosis of a terminal illness is that of shock and overwhelming anxiety. As they respond to the pain with denial and disbelief, the patient may say, "This could not be happening to me." The physician can assist the patient and the family in relating to the healthcare system. This aids the patient and the family in efficient and functional readjustment. Meanwhile, in a prolonged severe illness, adaptation and reaction are already set in motion. Death comes swiftly, and the physician effectively assists the family to cope. The patient and family may go through the stages of denial, anger, depression, bargaining, and acceptance. In summary, it is vital for family physicians to identify the stage of illness trajectory, as this directs us to detect normal and pathologic responses. The critical eye and the empathic responsiveness of the physician depend on how quick and sensitive we are to pick up the uniqueness of every stage and every meaning of an illness to the patient and the family. Engaging them in the cognitive and emotional planes increases our effectiveness in managing their concerns. Thank you for listening.